Good morning to everybody. So I will try to, these are some of conflicts. Everybody has conflicts, as we said yesterday. When you work with the guidelines, you should not have conflicts, but you cannot. You live in this real world, and so you cannot really stay away from this real world. But what is important, you need to be unbiased. So as long as you are unbiased, you can have as many conflicts as you want. So, what are the current unmet needs in non-muscle invasive bladder cancer? Well, I would say three. We have the low-grade disease, which doesn't kill the patient, but sometimes it does not respond to any treatment that we use. And so it's a problem. The risk of progression is not very high, but these multi-recurrent low-grade disease are really making the life of our patient miserable. So it's a matter of quality of life. Then we have the BCG-naive patients, the high-risk BCG-naive patients, the ones that, yes, they do respond to BCG, but still we know that in the long term, 50% of them will recur or will be resistant or will simply not respond to BCG, and they become BCG unresponsive, and they have a very high risk of progression. And of course, once you get to this stage, you know that cystectomy is the first-line treatment, but many patients are not happy, and many patients are actually not fit for having a cystectomy. And the question is, how does BCG works in this setting? Well, let's talk about patients who are at high-risk disease and have never received any treatment. Well, we look back to our retrospective data within the guidance panel, and what we found was quite surprising. BCG does not seem to work in the high-risk disease in terms of preventing the progression. It's the most, let's say, effective for preventing the recurrence, but it does not seem to impact on the progression rate. On the contrary, we have a very high-risk subgroup of patients. This is a minority of patients, around 5–10% of our non-muscle invasive bladder cancer patients. And if we look at this cohort, we could compare those who were treated with BCG with those that did not receive BCG, but they, for instance, receive intravesical chemotherapy. You can see that BCG has an impact on the progression. So the progression risk goes down from 50% at 5 years down to 25%. BCG is effective, but not enough. And finally, we have the intermediate risk disease, and again, the risk of progression is not very high, but there is no impact from BCG. So certainly, there is a room for having new treatment options. And finally, we look at the BCG unresponsive, those who have a very high risk of progression. If you look at this systematic review, which was done in 2020, you can see that indeed the results of what we call the second-line treatment when the patient cannot receive cystectomy, the results are very poor. We are talking about a 12-month response rate of 20% in these patients. So highly needed new treatment options. And how can we divide the innovative treatment strategies for non-muscle invasive bladder cancer? I will go through the new immune therapies, then the target therapies, the ones that actually target either the mutations that are pro-oncotic, or they simply go straight to target some, let's say, antibodies which are expressed by the tumor, and they kill selectively the cancer cell. Then we have chemotherapy combinations, which are very interesting. And finally, we have new treatment with new delivery systems. So let's start with the new immunotherapies. Of course, the first setting is the immune checkpoint inhibitors, which is a systemic treatment. And it has been shown to have to be effective in non-muscle invasive bladder cancer. The rationale is that these kind of treatments are very effective in the muscle invasive bladder cancer. And so we all know the pembrolizumab study. This drug was approved by the FDA. Indeed, it was very, very interesting to know that there was a 40% response rate in BCG unresponsive that were containing CIS. This is a special population of very high risk non-muscle invasive bladder cancer. And the fact that you give the treatment, and it was a systemic treatment, and 40% of the patient had the CIS which was cleared, it was very interesting. Unfortunately, the problem with the treatment is when you look at the curve, the response rate does not seem to last a lot. Also, there was a cohort of patients who did not have BCG, CIS associated, and in this case, what you look for is the recurrence-free survival. And the recurrence-free survival at 1 year with pembrolizumab was 43%. This drug was approved by the FDA, but later they published a study on atezolizumab with the results were similar. Complete response with CIS containing 43%. Again, the duration of the response is not very good. You see the curves are pretty much the same. This drug was not approved by the FDA. And the fact is that both of these drugs do not respect the minimum requirement of the FDA, because the FDA at a certain point realized that there was no treatment option for this kind of BCG unresponsive disease. They say, okay, if you find a drug which will give a complete response rate in CIS containing of 50% and the duration of response of 50% at 12 months, I will approve the drug. Unfortunately, as you can see, none of these drugs are really matching these requirements. Then, of course, ICI are going to be challenged in high-risk BCG naive, and there are 4 trials awaiting the results. And Professor Upre is a primary investigator in one of the trials, the Alban trial. Of course, everybody is very interested. And what is the rationale behind that? We maximize the response for a disease that has a fairly high risk of progression, and in this case, we reduce the chances to have a BCG unresponsive disease. Is there a rationale for adding immune checkpoint inhibitors to BCG in these patients? Yes. There is a study on BCG unresponsive where they looked at BCG, rechallenged with BCG, compared to atezolizumab plus BCG. And you can see this was just very few patients, but it seemed that the combination treatment had more complete response, and also the duration of treatment seemed to be better if there was a combination of BCG plus atezolizumab. And then this year at the ASCO meeting, they published a study on high-risk BCG-naive patients showing that the combination of atezolizumab plus BCG had a 2-year disease-free survival of 72%. How do you interpret these results? I would say promising. Promising because in the end, there is half of the patients that will not respond to BCG alone. So let's see what the results will say. Gene therapy. This is a fantastic new treatment option. The interferon gene is inserted in the adenovector, which will be captured by the cancer cells, and the cancer cells, the urothelial cancer cell, will start producing interferon. And this has been shown because if you give this kind of gene therapy and then you check the interferon in the urine, you have a high production of urine. The good thing of this drug is that it is extremely well tolerated. Now, these are the preliminary study. Again, they look at a population of BCG unresponsive that contains CIS, and you can see complete response 53%, a little bit more than pembrolizumab, but much better tolerated. Then they look at a population without CIS, 1 year recurrence-free survival, 43%. What is the problem again with the treatment? But you look, this is the 1 year follow-up, and you can see that the duration of response, again, is an issue. This year, they published the 5 years result of nadofaragere firadenovec, and again, you see the curves. It goes down. 80%, 88% of the patient had a high-grade recurrence. So this response is not going to last forever at 5 years. But what is the good thing? Only 3% of the patients at 5 years had a progression. This is extremely low. I don't know whether it is related to a selection criteria or is just because the patients who respond to this treatment, probably even if they have a recurrence, they have a slow progression. And 50% of these patients will keep their bladder. So I think that we can see the glass half empty or half full. It depends, but certainly there are sides of these results that are really, really very interesting. Another immune therapy is a combination of BCG with this IL-15 superagonist. Basically, it seems that if you boost the immune response to BCG and then we add this immunostimulatory agent, it seems that you have an additive effect. And indeed, if you look at this study, which showed again in a population of BCG unresponsive, that there was a 71% complete response. That's much higher than pembrolizumab, and the duration of response at 12 months was 56%. And in fact, the FDA approved this kind of combination, which is available in USA. And again, this immune treatment is extremely well tolerated. CG007, or Cretostimogene gredanelumab, is a very, very complex name. This kind of immune treatment is a non-colytic virus. Basically, this virus goes inside of the cell, and again, it kills selectively the cell. They did two studies. In one study, they combine this drug with pembrolizumab. So they challenged the treatment. And of course, the results were very good. 3 months complete response rate, 82%. 2 years complete response rate, again, maintaining 51% of the patient. The problem was that you had the addition of the side effects. So you had also the side effects of the pembrolizumab. They did another study with this drug alone, and you can see that the 3 months complete response rate is 75%. Again, it's very good, and the treatment basically has no grade 3 side effects. So certainly, this kind of treatment is a promising treatment. What are the considerations about these new immunotherapies? Well, of course, you have to keep in mind that immune checkpoint inhibitors can have severe side effects, whereas the other immune treatment appears to be extremely well tolerated, and they are all new intravesical immunotherapies. Target therapies. The most important target therapies if the therapy that target the mutation of FGFR receptor. And this is highly mutated in non-muscle invasive bladder cancer. 70% of this disease will have a mutation as compared to only 20% of the muscle invasive bladder cancer. And the FGFR mutated as an angiogenic and other oncogenic properties. And so it makes sense to use a drug that will block this oncogenic effect. Then there is another target therapy, which is called oportumumab bonatox. And basically, this is a combination of an antibody with a pseudomonotoxin. This antibody goes to link, let's say, an antigen which is expressed by the urothelial cancer cells. Again, this kind of treatment is quite interesting, but it turned out to be too toxic. So at the moment, the FDA has not approved this treatment. Whereas FGFR inhibitor has been attempted to be studied as an oral compound. And there was a study, a randomized study, which was published just a few months ago. As you can see, there is an effect of the oral erdafitinib in this case, but the problem is the toxicity. So this type of treatment was probably too toxic, and basically they had to close the study because of the poor accrual. Oportuzumab, as I told you, again, is not well tolerated. Chemotherapy combinations. This is very interesting. Gemcitabine plus docetaxel combinations. In patients with a BCG unresponsive disease, you can see 2-year response rate of 46%. These are retrospective study. There is a prospective study on high-risk non-muscle invasive bladder cancer, BCG naive. We will see the results. There has also been published this year at the AUA was presented a triple combination, gemcitabine, docetaxel, and cisplatin. If you see these results are quite strange. Complete response rate of 41%, but this series, which was probably heavily treated series, had a 31% progression rate. So I think that this triple combination maybe is something that we have to look more carefully. And then we have new innovative treatment delivery system, the TAR-200, TAR-210. You have a pretzel that you insert in the bladder. It delivers constantly for 3 weeks, either gemcitabine, TAR-200, or erdafitinib, intravesical erdafitinib. So the FGFR target, mutated target, is given in this case within the bladder. And then you have the Oncofit, which is a combination of paclitaxel plus hyaluronic acid, and the mitomycin C contained in a thermal gel, which is basically it attached to the bladder wall, and of course it allows a longer prolonged action of the drug. You can see here the TAR-200, the results. Basically, this is the Sunrise study and they publish only the results of the TAR-200 only, and you can see that in BCG unresponsive there was an overall complete response rate of 77%. So certainly this kind of treatment is promising. The TAR-210, you need to have the FGFR mutated. At the moment, we have 2 cohorts, very small cohort, BCG unresponsive or intermediate risk non-muscle invasive bladder cancer. And you can see that in the intermediate rate subgroup, there was a more than 70% complete response rate. This is a chemoablation effect in patients who have the mutation of FGFR gene. Again, promising, but we need more data. The Oncofit is also promising, well tolerated, because apparently the hyaluronic acid also reduces the toxicity of the paclitaxel, of the chemotherapy. And finally, UGN, the mitomycin thermal gel, was assessed in intermediate risk, and they compare TURBT with UGN, and you can see that the response rate is almost the same. More than 60% of the patients receiving this kind of treatment without TURBT, they had the tumor that was cleared. And at 12 months, after giving the TURBT to patients who did not respond to the UGN, you can see that the results in terms of recurrence rate is much better for patients receiving UGN. So the conclusion, you see that we have a huge armamentarium coming up. The future looks bright. We will have more treatment options. The question is, we have different mechanisms of action. We can use systemic immunotherapy or intravesical immunotherapy. The question is, do we have a game changer? Is there something that is going to change our practice? Probably in the intermediate risk disease, we will probably shift from doing too many TURBTs to just de-intensifying the treatment with this kind of intravesical compounds, which are well tolerated. In the BCG unresponsive disease, I'm not yet sure how much we are going to change the natural history of the disease, because we have a 50% around response rate, duration of response of 2 years, but we cannot at the moment make comment on what is happening at the longer follow-up. So thank you very much for your attention.